According to the latest data from the CDC and the U.S. Census Bureau, an estimated 6% of adults in the U.S. are currently experiencing long COVID symptoms. Here to give us more insight, Dr. Amish Adalja, a senior scholar at Johns Hopkins University Center for Health Security. Doctor, always a pleasure to have you on the show. Hearing that woman speak about the effects of long COVID is tough. You know that it's going to be a long journey for them. How will the end of the public health emergency policy affect treatment for people like her?
It really doesn't have a major impact. As you saw in your package, the HHS statement is correct that this doesn't really affect long COVID treatment, long COVID research. The public health emergency was really about the bureaucracy in the federal government being able to respond quickly to acute needs during COVID-19. So this doesn't really impact COVID-19 long haulers. Remember, just because something is not a public health emergency doesn't mean it's not a priority. HIV is not a public health emergency. Hepatitis C is not a public health emergency, but yet there's still research and progress going on every day. And I think that's what people should take away from that.
What do people need to know about long COVID that they already don't?
That is probably not just one syndrome, that we're really scratching the surface. We don't have a diagnostic test. We don't have even an agreed upon definition. And there's a lot more just basic science that needs to be discovered to actually know what's going on. And what we may see is that there may be multiple subtypes of long COVID. And it's going to take some time. Science doesn't necessarily move at the pace we want it to. This is going to be a very measured response, trying to understand what's underlying this, who's at risk, and what treatments can we offer them. So that's going to be something that is a much more longer-term research project, which will eventually get to the answers and sift through all of this.
And how difficult is it to diagnose long COVID as opposed to a diagnosis for just having the cold or the flu, something like that? How do you differentiate?
It's extremely difficult because, as I said, there's no blood test you can do to say this person has long COVID, this person doesn't. There's no diagnostic criteria or even a definition. So what we do is we think about people who have had symptoms after they've recovered from COVID that last several months, and we kind of have this constellation of symptoms of brain fog and difficulty exercising, fatigue, muscle aches and pains, and you kind of put people under that umbrella term. But what we don't know is if all those people are the same. We don't know if we're actually getting it right. We have to make sure that there's no underlying illness there that's being kind of masked by long COVID symptoms. So it's really not an exact science at this point. And that's why many research universities are putting together whole agendas to try and unravel the mysteries of this condition. And it probably exists for other infectious diseases as well, like influenza. There probably is something like long influenza. We just don't have that many people getting influenza at the same time to be able to notice it the way we did with long COVID.
Taking a step back from just long COVID, I think it's no secret that a lot of us have moved on from the pandemic, regardless of whatever state it is. What will the lifting of the public health emergency mean for the country as a whole as we navigate COVID moving forward?
For the average person on the street, May 10th is not going to be any different to them than May 11th. It's not going to be something noticeable. The biggest thing that people may notice in their day-to-day life is it may be a little bit more bureaucratic to get your home test reimbursed by your insurance company. It might be something where you have an out-of-pocket cost where then you have to submit paperwork. So that may be something that is troublesome for some people. In general, a lot of the public health emergency declaration is about moving the federal government in a faster way. So that involves nursing home waivers, the way telemedicine is regulated, certain things with other medications, that just the way the government can kind of move in a more nimble fashion. And that's what's going away. So it's not necessarily something that you're going to feel day to day. And as I said earlier, remember that all the other infectious diseases that we care about are not public health emergencies, and this had to end. The emergency conditions are not really in place anymore in terms of, are we worried about hospital capacity? Are we worried about vaccine development? No, all of that, those problems have been solved. So we're in a different place with COVID-19, and we have more tools for COVID-19 than we do for any other respiratory virus.
Dr. Amish Adalja, senior scholar at Johns Hopkins University Center for Health Security. Thank you as always for coming on the show. We appreciate it.